telling you I'm in awe at Dr. Bersin's accomplishments, and I've followed his work for the last many, many years. I've developed my own endovascular career. He is also the member of the Board of Trustees of the Society of Coronary Angiography and Interventions. He is a nationally recognized expert in the field of peripheral and endovascular intervention. Most recently, the two probably most remarkable achievements of his career right now are that he is the PI of the Viabahn ISR registry and also of the PI of the best CLI NHLBI funded clinical study that is going to be hopefully the landmark study that we all are participating in. So, Dr. Bersin, we are delighted to have you this morning, and of course you woke up very early to be with us. We want to share and listen from you about the Viabahn stents and the current experience, and we'll also have some questions at the end. And the entire meeting is going to be recorded, and I also request all the attendees to please mute your lines. If you do have a question, feel free to be on the chat and send us a text message through the chat line, and we'll ask those questions of Dr. Bersin. The entire meeting is going to be then presented and with the audio recording on the XLPAD website. So, Dr. Bersin, without further ado, please take it away. And once again, welcome to the XLPAD Forum.
Well, thank you very much, and good morning. So the Viabahn, when and how to use, what I'd like to do is first show you my disclosures, and relevant to this presentation is that I am a consultant and proctor for W.L. Gore Corporation, the manufacturer of this device. So first, let's discuss the device. The device has evolved over many years, and it's been in service for more than a decade. What has come from use of the device over the years are iterative improvements that have greatly enhanced its performance. And as you can see on the first slide here, there has been the addition of what's called a contoured edge on the proximal edge, which not only helps with the loading of the device, but this also decreases the amount of fabric at the proximal edge to reduce proximal edge interaction with the healthy native artery and issues with edge stenosis. So this has been a very significant improvement to decrease any fabric artery interaction at the edges. The other salient feature is that notice that the stent frame is a series of individual stent rings without connecting bars. This greatly enhances the flexibility and greatly reduces the risk of fracture. Fracture is distinctly uncommon with this device as a result of the fact that you have no connecting bars. The connecting segments, if you will, are the fabric, and the stent itself is embedded in the layers of PDFE. The other major addition has been the heparin bonding, and the device is heparin bonded throughout, which reduces the thrombogenicity of the device. What we have learned with clinical use of this device over the years, and the observation that's been made, is that recurrence risk of restenosis or occlusion, or on the other hand, the primary patency of the device, is independent of the stent length or lesion length. And that's because the fabric greatly impedes any neointimal ingrowth or tissue ingrowth within the device, such that restenosis or reocclusion can only occur outside the device. So what is shown here is a series of publications, with each dot being a published series, where you have a plot of patency as a function of the average stented length for each series. And you can see that there really is no trend for any interaction between stented length and graft patency. Very important observation. So what has followed since then, more recently, only a few years ago, was completion of a prospective randomized trial called Viastar, wherein for SFA popliteal stenoses, patients were randomized to either a bare metal stent implant or a Viabahn, with the pre-specified subgroup analysis by lesion length. And what you can see is, even though there appears to be no significant difference overall between the Viabahn and bare metal stents in the entire cohort, when you look at the pre-specified subgroup of long lesions greater than 20 centimeters, you see a distinct separation of the curves, especially going out to 1 year, in favor of the Viabahn with a better primary patency in longer lesions. And this makes sense because bare metal stents have a higher and linear recurrence risk as a function of lesion length, whereas the Viabahn does not. So that's proof of principle, if you will, that the Viabahn's recurrence risk is independent of lesion length. More to the point, there has also been a randomized trial comparing an endoluminal bypass with the Viabahn, if you will, as compared to synthetic FemPop bypass grafting. And this is the 3- and 5-year outcomes of the prospective randomized trial of the Viabahn as compared to surgical bypass, demonstrating that going out to 5 years, you have equivalent patency if an endoluminal bypass is performed with the Viabahn as compared to a surgical bypass. So these results would clearly suggest that the patient's long-term outcome will be just as good if you do a long lesion endoluminal bypass as compared to a surgical bypass with above-knee synthetic conduit. As a result of these findings suggesting superiority of the Viabahn in treating long lesions, a long lesion device was developed. A 25-centimeter Viabahn is now CE marked and FDA approved and marketed in the United States as a result of this single-arm prospective registry of the 25-centimeter device. Impressively, this enrolled patients who had to have 20-plus centimeter lesions, and so all of the patients enrolled in this trial were long lesion patients. And you can see going out to 1 year, you have a primary patency of almost 70% with the Viabahn in these extra long lesions using a single long 25-centimeter device. So when you put this data into perspective as compared to other technologies that are used for task C and D lesions today for long lesion treatments in the SFA, most notably the PTX Zilver drug-eluting stent, long bare metal stents, including the long Everflex, and drug-coated balloons, you can see in pink that the outcomes of the ViaStar trial that I've shown you and also the long 25-centimeter Viabahn registry compare very favorably and perhaps show superiority as compared to bare metal stenting and possibly DCBs. It's a crowded field, but what I can say from this is that from the 25-centimeter Viabahn trial, all of the patients had 20-plus centimeter lesions, whereas in the other device trials that I'm showing you, that was the average lesion length with quite a significant variation from shorter to longer lesions. So that the jury's still out on whether DCBs and DES perform as well in the super long lesions. The other category is in-stent restenosis. There have been 3 prospective randomized trials looking at different device therapies to treat bare metal in-stent restenosis as compared to PTA. On the left, you have the Excite ISR trial, which compared laser atherectomy plus angioplasty to angioplasty alone for bare metal ISR in the SFA. This, although the laser did improve the 1-year primary patency, it is still not really an excellent therapy in that regard, in that the primary patency of 1 year is estimated to be only about 40%. It's better than with PTA alone, but most of us would feel that a 40% primary patency of 1 year is just not sufficient. Although it helps, it's just not quite good enough. DCBs have also been examined for bare metal ISR, but only in short lesions. You can see the average lesion length that was studied in the prospective randomized FAIR trial was only 8 centimeters, but nonetheless, you can see that the DCB outperformed the PTA significantly with a primary patency that approached 70% at 1 year in short lesions. And then on the right panel, you have the Viabahn, which was compared to PTA in-stent restenosis in a prospective randomized trial where the average lesion length was twice as long as what was studied with DCB at 17.3 centimeters. Here you can see the primary patency of the Viabahn at 1 year is 75% in lesions twice as long as what was studied with DCB. So I consider this outcome the benchmark, 75% patency at 1 year in 17-centimeter lesions. Today, the clinical applications include not only de novo lesions that are at high risk for recurrence, long lesions, TAF C and D lesions, in-stent restenosis, but also lesions in bend segments where flexion is a significant issue because the Viabahn has very little, if any, fracture. As far as implantation, there are some technical tips I'd like to provide you with as to how to optimize your implant strategy. And there are several. I'll go through them briefly, one at a time. First, avoid excess oversizing. This is a key finding with the Viabahn trials that have been undertaken. You do not want to oversize this device 20% or more. If you do so, you will have problems with edge stenosis and recurrence. This was pointed out very well in the Viper trial, where the primary patency was greatly affected if the device was oversized more than 20%. So you want to be quite accurate in your sizing. Frequent use of IVUS is recommended, although not required. But keep in mind you want to do one-to-one sizing without significant oversizing. The other is treat all of the disease. You want to land the graft edges in healthy segments. What you don't want to do is land the device in a disease segment, as is shown in this example. This is likely to induce an edge stenosis and lead to occlusion, as occurred in this patient at about 200 days. On the other hand, you want to preserve collaterals whenever possible. This sometimes becomes an issue as to how far to extend the graft in order to land into healthy tissue. Most of us are very comfortable extending the graft into the above-knee popliteal segment, but typically we prefer to spare the geniculate branches if at all possible, because often patients will develop downstream popliteal disease and often rely on the geniculates for below-knee collateralization. Coverage of an above-knee profundifemoris collateral is generally acceptable because those collaterals are often numerous, and covering one, even if it's the largest one, will not lead to catastrophic failure if there is graft occlusion later on. You do want to lean and emphasize coverage of all the disease segments and land the graft in a healthy segment if at all possible. In using that application, what you see is that graft occlusion leading to acute limb ischemia is infrequent. And in all the publications, this varies only from 1% to 3%, and many operators have the misconception that when grafts go down, they go down hard and they lead to acute limb ischemia. This is generally not the case with the Viabahn. As I mentioned, you often have numerous sources for collateralization, and even if graft thrombosis occurs, it rarely leads to an acute event. As far as antiplatelet therapy, this is a topic for which we really don't have definitive answers and prospective data to guide you. The recommendations for how long to administer dual antiplatelet therapy and or anticoagulant therapy vary widely. Typically, most implanters will administer dual antiplatelet therapy for a period of 3 to 6 months at a minimum, though there is no pre-prescribed absolute IFU recommendation on this topic, and there is renewed interest in studying whether or not anticoagulation and or the 10A inhibitors improve graft patency, but this is not well studied. The other thing is to make sure that you have adequate inflow and outflow. There are long lesion cases where the patient has critical limb ischemia and downstream tibial perineal disease that can really impede outflow. And synthetic grafts definitely need good inflow and outflow to maintain patency. Here's an example of a patient who had an above-knee long segment disease segment that was treated with a Viabahn. In downstream, there was a single vessel runoff with a short segment CTO, and that is a clear indication to treat to maintain inline flow to the foot to help maintain upstream patency of the graft. The other issue is what to do at the SFA origin. Many implanters will land the graft short of the origin to not involve the profunda femoris in the treatment. Often this will lead to failure, especially if there's disease in the proximal segment. We generally recommend landing at the origin if the origin of the SFA is diseased in any way. And typically you can, now with the contoured proximal edge, you can override the graft by 2 or 3 millimeters without obstructing the profunda femoris. The other thing is to use generous overlap when you're using multiple devices. You want at least 1 centimeter, but 2 or more is preferable. There is no penalty for longer graft overlaps since they're fabric lined. There's no risk of recurrence in the overlap segments. What you can see, though, is migration of the grafts and separation of the grafts if you have insufficient overlap, as shown in this case. I've seen this myself in one instance. This is another example from someone else where at 485 days there was separation of the grafts, which clearly led to a focal stenosis in between. The other thing is to do high-pressure post-dilation of the device. The graft is not a high radial force device and relies on high-pressure post-dilation to smooth the graft folds and to achieve maximal luminal gain. Now, in doing so, when you high-pressure dilate the graft, you should stay well within the confines of the graft and not extend out beyond the graft edges. You do need to dilate the graft edges because they are not completely expanded. That should be done at low pressure. So the high pressure should be maintained within a few millimeters of the graft edges as shown here. If you dilate, if by chance you have a geographic miss and you dilate outside, expect the barotrauma to result in intimal hyperplasia. Today, some operators are applying a drug-coated balloon in that instance to reduce any chance of recurrence. The other option is to extend the graft with another device. But if by chance you do dilate geographically outside the confines of where you land endografts, you should consider doing additional therapy other than PTA to prevent a recurrence problem. So now what I'd like to do is just conclude with a case example that I think illustrates the benefits of the device not only for treating de novo lesions but also for ISR. This patient is a patient of mine I first evaluated in 2012. He was 64 at that time with the usual high-level risk factor profile, including hypertension, diabetes, and hypercholesterolemia. He had Rutherford class 3 claudication symptoms on minimal exertion as a result of long SFA occlusions bilaterally. And you can see both are extensive occlusions measuring about 40 centimeters with the typical above-knee collateralization from the profunda femoris arteries. At that time, I approached the right superficial femoral artery CTO at first and recanalized that using a combination of the crosser and pioneer reentry devices. And because of the long nature of this occlusion, treated him with several Viabahn endografts. This was at a time before we had the 25 centimeter device. The total graft length was 40 centimeters. And he also had an upstream external iliac stenosis that was treated with a bare metal stent. The following month, he came back to have the left superficial femoral artery CTO treated. He had had an intervening GI bleed in between that time, and so when I treated this, it was due to ulcerations. When I treated this, I chose to treat him with bare metal stents to minimize his need for antiplatelet therapy, dual antiplatelet therapy. So on that occasion, the left was performed just 1 month after the right using 38 centimeters of bare metal stent. So he did well for the ensuing year. About 18 months after those treatments, he came back with symptoms in the left lower extremity only, with recurrent claudication symptoms. A duplex ultrasound demonstrated occlusion of the bare metal stents in the left superficial femoral artery, and excellent patency of the right external iliac bare metal stent and of the right superficial femoral artery Viabahn endografts, with an ABI of only 0.48 at rest on the left. Here's his angiogram. This is now August 2014. On the right, you can see widely patent Viabahn endografts, and on the left, occlusion of the bare metal stents, Everflex stents. And as you go down, it's an extensive occlusion, but there is, again, good reconstitution of the below-knee left popliteal artery via profunda collaterals. So I managed this long ISR occlusion initially with laser atherectomy because most of that occlusion felt hard and fibrotic. I then did rheolytic mechanical thrombectomy with a Solent angiojet. And you can see in the middle panel, it was persistently occluded and perhaps with chronic thrombus in the channel. So I chose to do ecoslysis overnight. Patient came back the following morning, and you can see that even after ecoslysis overnight, there was persistent occlusion of the graft. But after doing additional thrombectomy, you could see that the lysis probably toughened up quite a bit of the chronic thrombus, and a flow channel was restored with varying degrees of hyperplastic restenosis throughout the stented segments. I did additional laser with a turbo tandem to further debulk the hard diffuse fibrotic ISR disease, and then relined the entirety of this 40-centimeter occlusion with additional Viabahn endografts. I think it required two, a 25 and a 15, 6-millimeter devices to do so. This was in August 2014. At 1-year follow-up, this past July, just a few months ago, the patient returned feeling well one year after relining the left, and you can see his ABIs are normal. Both SFAs, the Viabahns, are widely patent without stenosis, and the patient continues to do well. So I believe this is an excellent example of a patient who, with long TAF CTOs, did extremely well with Viabahn endografts, but with bare metal stenting exhibited extensive restenosis. And even after relining the left one, he continues to do well with the Viabahn with no evidence of a secondary recurrence. So in conclusions, what can we say about the current status of the Viabahn, the current status of knowledge? Recurrence risk is clearly independent of lesion length with the Viabahn. As a result of this, use of the Viabahn is superior to bare metal stents in task to type C femoral popliteal lesions that exceed 15 centimeters, and that was convincingly demonstrated in the Viastar trial that I showed you. The results of intervention with the Viabahn are equivalent to surgery in the prospective randomized trial comparing the Viabahn to synthetic above-knee bypass graft surgery with data going out to 5 years. And the available data would also suggest superior outcomes with use of the Viabahn in TAS2 type C ISR lesions based on the RELINE trial. Thank you very much.
Thank you, Dr. Bersin. That was awesome. I can't thank you enough. It was not only rich in content about Viabahn, but I think the audience appreciated a lot of the practical tips from an expert operator regarding dealing with complex femoral popliteal lesion and below the knee lesions. I think your tips regarding how to deal with osteal lesion was right on the money. And I think many a times if that area is left untreated because of just apprehension, it actually leads to worse outcomes. Before I open it for questions, I just have to make a pitch because that's my job, is that we have the XLPD registry, which is an unbiased registry which is collecting and currently has over 2,500 core lab adjudicated procedures, and maybe you will consider joining us. And second is that we do have a randomized study ongoing from UT Southwestern, randomizing patients to 1 month versus 1 year of dual antiplatelet therapy after iliac and femoral popliteal interventions, and maybe you would consider joining us too. But those were my pitches, but I greatly appreciate your presentation, and I want to open the floor to questions and comments from the audience. And if there are a few, and I have some of mine, but I'll give the first chance to all our guests who have joined in this morning. Please go ahead and unmute your lines if you have comments and questions for Dr. Bersin regarding Viabahn or in general. He's an expert in this area, and I think you will have some great tips from him. So take it away, anyone who wishes to ask any questions. there is a question on the chat line, which I want to ask you is that when you deal with ISR lesions, and sometimes when we balloon these lesions, we see that there is still a lot of neointimal tissue that between the lumen and the stent. So how do you size your Viabahns in those situations? And second, the fact that the Viabahn sometimes in ISR lesions may look not completely expanded, does it raise your concern for using Viabahn in long ISR situations? So if you could please, because the stents are not completely symmetrically expanded in those situations.
Yeah, it's an excellent point, and it's worthy of a few comments. I should begin by saying the RELINE randomized trial that was performed comparing PTA versus the Viabahn in ISR lesions did not include atherectomy. It was PTA versus PTA plus Viabahn, and you saw that the primary patency going out to 1 year was excellent, 75%. So without debulking, very good outcomes, benchmark outcomes can be achieved. That being said, we all have had the experience, those of us who have treated ISR lesions, that the ISR in the SFA can be hard and fibrotic and can impede the ability of any stent system to expand, especially the Viabahn. So you saw that in the case example I showed you that I debulked the in-stent restenosis with the turbo tandem laser. That is frequently done, but the outcomes data to demonstrate that the outcome is better if you debulk before applying the Viabahn in order to get better stent expansion, we just don't have yet. We don't have an organized database or a prospective trial of any form of debulking prior to implantation of the Viabahn. That being said, high-pressure dilation can usually result in good graft expansion. As far as sizing is concerned, many times you will have, for example, in an SFA, a 6-millimeter bare metal stent. I will typically try to reline it with a 6-millimeter device and post-dilate it under high pressure at 6 millimeters with a 6-millimeter high-pressure balloon in order to get the greatest degree of expansion of the device. Thrombosis.
No, go ahead, please. Go ahead. I just have a follow-up question on this issue because Dr. Gelati from Austin is chiming in, asking that, the sizing sometimes in ISR lesions may be a question, especially for those who don't use Viabahn all the time. If you could just give us some hints about how do you size, like if the 6-millimeter stent, you go with a 5, or how you oversize, undersize, and how does the distal vessel play into the picture?
Yeah, so like I was mentioning, even if there's a fair amount of hyperplastic tissue in a 6-millimeter bare metal stent, I'll still use a 6-millimeter device or try to. Yeah, especially if the distal vessel looks like one that would accommodate a 6-millimeter, and you're not more than 20% oversized in the native vessel beyond the ISR segment.
I see.
The 5-millimeter device, as you go down in size, the risk of thrombosis goes up, and that's true with all synthetic grafts. So we tend to try to maintain the 6-millimeter device in the SFA if possible, but again, you don't want to do more than 20% oversizing. So if it's a small vessel, it's probably more appropriate to stay with a 5.
That's an excellent point. Excellent point. And another question is regarding, in your own practice, does the complexity of the lesion you're treating have an impact when you're treating with Viabahn on the duration of dual antiplatelet therapy? That's probably an experience question. There's not much data, I realize, but how do you decide on it?
Yes. Well, my personal practice, I recommend that all the patients stay on dual antiplatelet therapy for a minimum of 6 months. Now, like I mentioned, I don't have data on this. We don't know. Sure. But the higher the risk the case, the longer the CTO, the worse the runoff or inflow, the longer I will recommend that they stay on dual antiplatelet therapy. And honestly, I think the treatment with low-dose aspirin and a 10A inhibitor should be studied, because anticoagulation with warfarin has been demonstrated to improve graft patency for surgical grafts. So, that literature is fairly robust. It's just an unstudied thing with the Viabahn. But for me personally, I will typically, all the cases I use it in are usually fairly complex cases, And so I'll often recommend after 6 months, even if they're doing well, to stay on dual antiplatelet therapy, provided they're not having any complications.
Steve, I just want to call on you. You just chimed in about Vorapaxar. Anyone has used Vorapaxar in these situations? Because that has also come up based upon one of the recent studies, TRA2P. Any experience, Dr. Bersin, yourself using this drug, or anyone else who has used it?
Not
I have
yet.
used it a few times. You have not. You have not.
I have not. Mm-hmm.
One personal question for me, this is for my own sense, is that, I'm not a very prolific Viabahn user yet, but I've started to use it in situations where other devices have not worked very well, and most recently I've used it in popliteal cases. So when you truly have a popliteal lesion that actually requires some sort of a vessel scaffold, what are your thoughts regarding using Viabahn in the situation? I know this is something you probably have done many times, but for those who have not, if you could just tell us some thoughts, what are the things to consider and what are some do's and don'ts?
Yes. Well, the principles of application of the Viabahn are pretty much the same regardless of lesion location, in that use of it, you want to make sure that you have good inflow and outflow and you can land in good, healthy tissue in a vessel that's of good size and appropriate size for the device. I don't hesitate to use the Viabahn in the popliteal segment. In fact, I've done many, not only atherosclerotic lesions in the popliteal segment, but also aneurysms, popliteal aneurysms.
That's an excellent indication, yes.
And the stent is extremely flexible. It will not fracture hardly ever, and even if it does, an individual stent ring fracture is normally contained within the fabric, and so there really is no consequence of it. That is one of the few stents that can really withstand the rigors of flexion, in the popliteal segment and tolerate that well. You just want to make sure that you have good outflow. I think that's extremely important, and that you can land in a reasonably healthy segment. So often when you get into the popliteal segment, especially as you approach the knee space, often the disease is more diffuse and involves the knee space and distal below knee popliteal artery, and it's hard to find a good landing zone.
Sure.
But if you have a good landing zone, and that's the best treatment for the patient, and it's a good size vessel, I wouldn't hestate.
Final question that I absolutely have to ask, and I'm sure many of the attendees do have. How has drug-coated balloon data affected your practice most recently?
Quite a bit. The 2-year data for the Admiral device, as I'm sure you're aware, was presented at TCT last week, and clearly showed no loss of effectiveness at 2 years. And so we have a device that has a durable outcome, and that has really gained popularity, not just generally, but especially in my practice. Yesterday, 2 of my 4 lower extremity interventions were treated with DCB as the final treatment. One or two had atherectomy prior to that. But the point being is they were finished and completed treatments without scaffolding. And the outcomes speak for themselves. They do extremely well. So it has impacted my practice significantly.
That's fantastic, Dr. Bersin. I hope you can appreciate this forum is a pretty open, independent forum in terms of talking about strategies of endovascular intervention, especially located to the femoral popliteal iliac and below the knee intervention. So I can't thank you enough for taking the time and waking up very early. I'm sure your day starts very early, but having this on your agenda probably has affected your life in some way. And for that, I'm very, very grateful on behalf of all the members of the XLPAD team and also on behalf of all the attendees. I think the main focus of your talk, which I personally like very much, is this is not only just about a device, but in general, strategies to deal with fairly more complex situations that we all encounter in our daily practice, because none of our patients are focal and with discrete lesions. So these tips were extremely helpful. We are going to post this entire talk on the XLPAD website and also on our social media. So please feel free to join in. And again, Dr. Bersin, thank you very much. And I hope we can encourage you to be a part of XLPAD and also of the ASPIRE dual antiplatelet therapy duration study. So we'll be in touch. And again, thank you for taking the time. Any final comments parting comments from you?
Well, you're welcome, and thank you very much for the invitation. I think this is an excellent forum for dissemination of information in the treatment of vascular disease, so you're to be applauded for your efforts. Thank you very much.
Thank you. And for the fellows and trainees, what we do is that along with with your presentation, we actually post a PDF article of your choice on the website, and we'll put together 2 or 3 multiple choice questions with a didactic content that will follow the presentation. And all that can be accessed without any charge, without any login through the XLPAD website. Again, thank you all for taking your time for joining this morning. Again, we thank all attendees and look forward to another webcast next month, generally on a Thursday. Thank you all and have a great day.
You too.
Bye-bye.
Bye-bye.